Broadcasting live to the world at www.realurbanradio.com. Your home for today's R&B and old school.
UnControlled Substance. UnControlled Substance.
Welcome to Uncontrolled Substance with your host, Dr. Cozzette Lyons-Jones, Chief of Adult Medicine for the Watts Healthcare Corporation.
UnControlled Substance.
Welcome. It's 2021. Can you believe it? We're back to the future on Uncontrolled Substance with Dr. Cozzette. And we're doing things a little bit differently in the studio on today. We typically have myself and my partner in crime, Mr. Lena Jones, but he is at home with our son listening. And in the studio on today is our daughter, Lena Jones. Welcome.
Thank you for having me.
Welcome. So we're excited about this show. Lena has curated topics and done the research, and she'll be interviewing our special guest, Dr. Chandra Ford from UCLA. She's an associate professor of community health sciences and founding director of the Center for the Study of Racism, Social Justice, and Health at the Fielding School of Public Health at UCLA. I'm excited about her, and she'll be with us in the in the waiting room. But up top, we wanted to kind of lay the groundwork for today's topic. And it's a heavy topic, I know, and it's beyond the scope of a 1 hour presentation for sure. And we'll be doing a series of circle backs on this one for sure, right?
Yes.
However, we want to hit it. So episode 9 is Fatal Skeptics, How COVID-19 Vaccine Fears Stem from Historical Health Rights Violations Against Minorities in the United States. So we're in the check-in, just like in the clinic. You check in before you get seen, right? So go ahead and check us in, Miss Lena.
Yes, indeed. This is a deep topic. We have to consider multiple different factors that account for poorer health outcomes for minority communities, especially for the Black community when compared to white people in the United States. You talk often about dismal social determinants of health, including lower average income and educational gaps that usually lead to less health literacy that affect health outcomes of Black people. But today's focus is the history of discrimination and structural racism that has led to mistrust and distrust of the medical system among Black people and among minorities in general, because if one minority community is afraid, that permeates to the rest, right?
Right.
We can't be free until everyone's free.
That's right.
So we have to first define racism, right? So racism, as we're going to use it today, is more than dislike or prejudice. It describes a hierarchy in society with negative legal, social, and systemic consequences for those who are in the minority or perceived to be less than in society. So we're going to dig into those legal ramifications, social ramifications, and systemic issues that all lead to those poorer health outcomes and are rooted in racism. And so a New York Times article states that disparity is built into the healthcare system. And so this means that the laws, policies, and societal norms we have in place often lead to poorer health outcomes for minorities. So we're going to provide you with those examples. We usually think about the Tuskegee experiment, and that in and of itself was a terrifying time period, 40 years of Black men being lied to, being told they were being treated for syphilis, not being treated, spreading it to communities, dying and suffering due to research. But that's not the only example.
Right.
And so for example, there were thousands of non-white women that have been sterilized without consent in America and in American territories due to legal decisions. And we're going to get into that right now. So, for instance, 1/3 of Puerto Rican women of childbearing age between the 1930s and the 1970s were sterilized, many under coercion, not told that the process wasn't reversible, and it was due to the legalization of contraception in Puerto Rico, coinciding with the Puerto Rican government's passage of a law allowing sterilization, and then the U.S. government sending in public health officials, moving them in, letting them sterilize these women without their full consent. And so that's just one example of the law allowing racist outcomes. And so we can talk about Native American women who were sterilized, 25% of them in the 70s. We can talk about in California, eugenics laws, and how men and women of Mexican descent were sterilized, all legal ramifications. But we're going to go into now the systemic part, which is research. So sickle cell disease oftentimes isn't given the research of other diseases, and we know that it primarily affects people in the African American community. And so this bias that we see in research permeates into how research priorities are established, and that in and of itself is a systemic racism problem. And lastly, we can get into the social aspects. We can talk about how needless suffering and perhaps death from underprescribing appropriate care and pain medication to Black people has burdened the Black community. And that's due to, in short, just Black bodies being undervalued and the pain of Black people being met with apathy over time. And we'll get more into that later.
Right. So looking at it from my vantage point as a physician in the healthcare system, there's a New York Times article that said that Black patients with Black doctors received 34% more preventive services in a study where African Americans were randomly assigned to Black and non-Black doctors. However, only 4% of the current physicians and less than 7% of recent medical school graduates are Black. So many Black patients will not be able to see a Black doctor, just based on the numbers.
Yeah.
One simple means of removing some bias from the exam room is for Black patients to actively seek out Black doctors. But this isn't, a cure-all, Indeed, Black doctors have been suppressed in the medical community since they first began to practice in America. As the immediate past president of the AMA, the American Medical Association, founded back in 1847, Dr. Ronald M. Davis publicly apologized to the National Medical Association, which is the predominantly African American medical association that has been in existence since, I think, about 1895. In 2008, he did a public apology at a National Medical Association forum for over a century of AMA policies that excluded African Americans from the AMA, in addition to policies that barred them from some state and local medical societies. That's important because medical society membership brings professional advancement. It's a forum to present papers and to learn the latest techniques and treatments and things. And we were excluded as African Americans, as people of color, from membership. So without membership, the few physicians of color in America had less referrals for work, had limitations on their sources of income, and limitations on educational opportunities. So there was a significant impact early on that colored the access to care for patients in general, and especially people of color, as a result of the barriers to those who are in the workforce, who are people of color themselves.
Definitely. And we see that even the name of the American Medical Association has deep connotations, right?
Right.
Because calling oneself the American Medical Association instead of the National Medical Association, which it was originally named in 1846, changed the name in 1847 to American Medical Association, only inclusive of those who they considered American at the time, not Black and brown bodies.
Teach, baby girl, teach. I want people to be clear, though, because a lot of people may not be able to connect because it's abstract as to how we can say that racism is a public health crisis, and that is why we have an expert on the show today in Dr. Ford to be able to help us to lay the to make the case, for that. It's important for us to do these things. When we look at historically things that we find commonplace that we do today is on the backs of Black and brown bodies, particularly women. So I'm thinking about Dr. Sims, Dr. James Marion Sims, who was responsible for designing the speculum, the vaginal speculum that we use to do pap smears to check for cervical cancer. He developed that as well as treatments for management of fistulas, and he built his reputation and became successful in the medical community doing these, techniques and developing these techniques and tools. He would eventually serve as the president even of the American Medical Association and was dubbed the father of modern gynecology. So Dr. Sims only improved the surgical treatment by experimenting on enslaved black women. So the history of American gynecology is particularly associated with the institution of slavery, right? A well-referenced survey, if we fast forward to 2016, showed that about half of white medical students and residents in the sample supported beliefs and biological differences between the races that are false. 25% of medical students agreed that black people's skin is thicker than whites. So you have a lot of myths that are out there, that our pain thresholds are higher. And that was justification for slave owners, back in the day, to be able to do the cruel treatment, physically of slaves because of this quote unquote belief that our pain thresholds were higher and that we could take it. So these are things that are still embedded in the healthcare system on today and is coloring treatment of our patients.
And especially found in gynecology, right? Dr. Sims' very own in bread and butter. And so that in and of itself speaks to how the past has stayed with us.
Right. And everybody knows about Henrietta Lacks, right?
Yes. I actually was able to read The Immortal Life of Henrietta Lacks when I was younger at my mom's, pushing me to. And so the story of Henrietta Lacks has become public knowledge. She was a black woman who became known only through the abbreviation HeLa, the code name given to the world's first immortal human cells, which were her cells cut from her cervix just months before she died of cervical cancer. And so her cells were taken by the surgeon who was operating on her, and he used them put them in a lab. And they were the first cells to ever reproduce outside of the human body, and to continue growing and to be able to be used in different experiments and research for the genes that cause cancer and those that suppress it, for developing drugs that we use to this day. So her cells are immeasurably important to the medical research community, and yet she was not compensated. She was not told that her cells were being taken, and now her family's genome is out there in the world, where their private knowledge is used consistently by researchers.
Right. And so we see a continued disrespect of black bodies, not just in life, but also in death. We know that there's an abundance of more precise examples of racism embedded in the legal, scientific, and social aspects of medicine. However, when I think about the fact that even dead bodies of black people were being stolen, from grave sites and used as cadavers in the medical schools, there's a disrespect that even goes beyond life to the grave. And these are the things that we need to address. Yeah. So today that we're going to do some unpacking in these areas. This is only a sampling of the historic studies that we have cited, and we'll cover more on future shows. But we have Dr. Chandra Ford that's on the show today, and she will help us to kind of delve deeper and see the relevance of all this to today and the impact and what we can do. So for us, as we move into the waiting room, we'll talk about what's been going on around the country relative to the pandemic, especially because I know that's top of thought for everyone. On Uncontrolled Substance with Dr. Cozzette. We'll be back in a moment.
Uncontrolled Substance. Uncontrolled Substance. Uncontrolled Substance.
Welcome back to Uncontrolled Substance with Dr. Cozzette and my sidekick for today, my daughter, Lena Jones.
Woo!
Yeah. So we're in the waiting room now, and a lot's happened since we were last on the air. The first case of COVID-19 in the U.S. was 369 days ago. Can you believe that? Time just is going by us so quickly. President Biden signed executive orders on day one requiring masks to be worn on all federal property, making good on his campaign promise. But the president has an uphill climb to meet his goal of 100 million vaccine shots into arms in his first 100 days in office. Per the CDC, about 16.5 million vaccine doses had been administered as of the 20th of this month. And this is short of the 20 million doses by the end of 2020 goal of the previous administration. As we know, Biden inherited a no vaccine distribution plan to speak of from the Trump administration. And so that has been challenging for the initial rollout of this vaccine. This is the largest public health intervention ever done,
Wow.
right? And attempted in the midst of peak time of number of cases and deaths and hospitalizations, in the midst of workforces that are stretched already. Storage and handling requirements with the first generation vaccine manufactured by Pfizer and Moderna has also been problematic in some instances. And allocation depends totally on the federal government and is done on a per capita basis, so that's out of the state's control. Rollout differs from state to state, with each state having its own set of priorities about who gets it first, based on recommendations from the federal government. Rollouts is based on categories of need. Healthcare workers and nursing home residents are the highest priority, as you know, but the definitions have been expanded, but demand is outpacing supply. What's challenging here is that people are confused. A lot of people, if you just go to the level of the individual, where do you go to get the information to find out if you even qualify or if you're eligible? How do you sign up? And then once you get the first dose, are you guaranteed to get the second dose? These are the questions that are top of thought of many people across America, and it differs by answer from state to state. So I encourage our listeners to go to your local public health department websites. And WebMD.com actually has a good summary there, and they do it state by state for you to get vaccine information. Because it's not the same. What's happening here in California where we live is different than what's happening in the Midwest. It's different, across the country.
Definitely. And that's how it should be, right?
That's how it should be. However, it's problematic because one size doesn't fit all. And it's confusing because I can't talk to my mother-in-law in Texas and tell her how to go about getting it because the rules may be different. Mm-hmm. So that's where, it's not so good, right?
Honestly,
yeah. So when I think about LA County in particular, the challenges here is that, of course they prioritize, for healthcare workers and high risk, people first. But currently the public health officials, they are behind the eight ball on this. They prioritize those persons who got the vaccine first to get the vaccines, the second dose, over those people who may be getting the first time injection, of the vaccine. And so that creates a shortage in of itself because the number of doses available for first time recipients is less. So that creates a demand issue right there as far as the supply here in the local. And even when you drill down to the county levels, it differs from county to county because that's how they did it in LA County. But then if you look in Pasadena, also, out here where I live, Pasadena just said we're all comers, first time dose. We're going to, hedge our bets and hope that we get the second batch, enough of the second batch to be able to immunize our communities. And they just, went for first time, recipients of the vaccine. So it's been quite challenging here in California as far as all of that goes. But, we see the numbers climbing. And it's important for us to do everything that we can. And I'm confident with the new administration and with, people with expertise in the area at the federal and state and local levels that we'll have a more concerted, rollout as we go forward and be able to reach more lives. But the numbers right now, 800,000 injections are being distributed, per day.
Yeah.
And if we keep at that rate, they said that we won't have everyone immunized until
February 2022.
Yeah. So we would have to double that, meaning give 1.6 million injections in order for us to achieve complete vaccination of all of the citizens across the country by the summer of this year. So that's a behemoth endeavor right there in and of itself.
Definitely. And even as we have confidence in the new administration, I definitely want to go reach out to my college students, the people my age, and really implore you to stay home as much as you can, to be very safe around your relatives, and to think about the people that you're impacting on a daily basis. So from there, we can talk about how the World Health Organization has sent a 13-person team of scientists to Wuhan, China, to investigate the origins of the coronavirus disease. And that is notable because the Chinese government has pushed back against a lot of the investigations thus far. They pushed back initially, even jailing a journalist, Zhang Zhan, who was recently sentenced to 4 years in prison for giving her own updates on the pandemic's effects in China. So it is a political struggle to get the answers to what happened, to bring about where we are now.
And then additionally, the virus is mutating. So we're rolling out a vaccine, and the virus is so smart that you have the South African variant, you have the Brazilian variant, you have these new varieties of the vaccine that's out there that is of concern.
Definitely. And we expected this to happen. That doesn't make it any less scary or concerning.
Right.
But we did expect this to happen because viruses reproduce at such a rate that variants are very common in viruses. So now it's about rolling out that vaccine and reaching some sort of herd immunity.
Yeah, that's the goal. But there are many obstacles and barriers to that. We look at the death tolls, and it's incredible. We had a moment of silence, last week with our new president. 400,000 lives gone. And every time I say it, I have to pause, and it makes me emotional. That's hard.
Yeah.
That's hard. And our hearts go out to all the families and those affected. But we're all affected in some way by this, and it may not touch you, in the immediate sense, but as a nation, we stand together in solidarity, and our hearts go out to all those who have been impacted, whether it's by family members who are just going through the struggle of having the disease and not necessarily succumbing to it, and then those who, suffered and died.
Yes.
This is all the things that are at the feet of our current president. So our prayers go out to him. And the administration, the new administration, Dr. Fauci, coming in as the chief medical advisor for the new administration. This is all important. When we look at the numbers, it makes it even more important for us to push to get people immunized, for people to weed through the minutia of the lies that have been put out there and the misinformation, and to get the facts, and to weigh those things and to weigh that against the context of which they would be receiving that vaccine, looking at your own risk, looking at the medical conditions that you have. All of these things are factors, but sometimes even those who desire to get it, they can't, and that's what this show is about. Today is the deficiencies in the areas of social determinants of health. Yeah. That makes it less likely that certain communities will receive the vaccine even if they want it. And then you weigh that against the communities that are struggling just to wrap their mind around whether or not they should take it because of historic atrocities that have been, played out throughout history, not just here, but all around the world, but particularly here in the U.S., as we said in the check-in. So these are the things that we're going to kind of unpack a little bit on the show today with our guest, Dr. Chandra Ford. Dr. Chandra Ford is Associate Professor of Community Health Sciences and Founding Director of the Center for the Study of Racism, Social Justice, and Health at the Fielding School of Public Health. She is lead editor of Racism, Science, and Tools for the Public Health Professional. After a doctorate in health behavior from the Gilling School of Global Public Health at the University of South Carolina, she completed postdoctoral training in social medicine at the University of North Carolina and in epidemiology at Columbia University's Mailman School of Public Health, where she was a W.H. Kellogg Foundation scholar. Most of her research falls into two broad areas: empirical research, examining the relationship between specific forms of racism and disparities in HIV diagnosis and care, and conceptual and methodological work to improve the tools available for study of racism as a public health issue. So this is why we have her on the show today. We bring the best because you are worthy of that. Our listeners should get cutting edge information. They should get accurate information and not spin. And so we're not here to spin it. We're here to win it, right? Because we're all in it together. So we are very pleased and excited to have Dr. Chandra Ford here on the show. And Dr. Ford, can you hear me?
Absolutely. Thank you for having me.
Thank you. It's just the topic is too enormous. This is your whole life's work, and we cannot condense it in a few moments, I'm sure. But I pray that we'll be able to leave some nuggets for our listeners to be able to walk away and ponder, and it'll empower them to make decisions from an educated perspective. But we welcome you on the show today.
Yes, thank you for being here and for offering your expertise. It's been terrifying to see the impact of racism on the people that have sought care for COVID-19, how that legacy is bringing poorer health outcomes to people like Dr. Susan Moore, whose video online went viral, and her passing away due to COVID as a doctor was particularly terrifying. And so we're really grateful for your expertise here today.
Thank you.
So, before we have about 25 seconds, and then we'll be going officially into the examination room with you. But I want to start up top by asking you the question of how is racism a public health crisis? Like something just very basic. And you can maybe start the answer now, and then we can pick it back up when we come back in.
There's several ways that it's a public health crisis. Number one, historically, as you were already talking about, our field has been founded on and based on and relied very heavily on medical racism. And by that I mean forms of racism that occurred within medicine, within biomedical sciences, within public health. And so because that's our foundation...
Hold that thought for 1 second, sweetie. We'll be back in 1 second on Uncontrolled Substance. We're just going to pop out and we'll pop back in and we'll take up the conversation in one moment. Thank you.
Uncontrolled Substance. Uncontrolled Substance. Uncontrolled Substance.
Welcome back to Uncontrolled Substance with our guest, Dr. Chandra Ford. You have the floor, my dear.
I would just say that there are at least three ways that racism is a public health issue. First of all, it really is a core part of the foundation of our field. Secondly, any disease, and any time we see disease and death happening along the lines of race and ethnicity instead of along the lines of actual factors related to the disease, it should give us pause. We would expect rates of disease to be worse not because of one's race or ethnicity, but because of factors related to the condition.
Right.
And so that signals to us there's a problem here with what's happening in our society around race and ethnicity. And then the third reason is because we have done so much work over the last at least 2 decades. A number of researchers and scientists really trying to understand, to shift the gaze from focusing on what is it about black people that makes them have these high rates of disease, which is such a problematic way of framing things, and shift that gaze toward asking the question, what is it about the conditions and the experiences that black people have and survive that leads them to have poorer outcomes? And that work has actually been showing that racism and by racism I mean a whole lot of different more specific things, is at the root of so much of the health disparities that we see, including disparities in COVID.
On that point, I'm really interested in why COVID was the perfect storm to reveal the cracks in and undermine the integrity of our healthcare system. Why COVID? Why this disease and the outcomes that we're seeing now?
You know, in any epidemic or pandemic, racial fissures become apparent, and we saw this with the HIV epidemic. What's striking about COVID is that there's not a lot of buffer in our system, and so because COVID was such a fierce, or is such a fierce enemy, if we want to think of it that way, the impact has been very, very stark. It's been so apparent because there's not a lot of wiggle room there for us to kind of mask what's actually going on. So some of the things that contribute to this perfect storm include decreasing investments in things like infrastructure, public health infrastructure. There are a number of states, I believe about 12 at this point, who have not actually adopted Medicaid expansion, and that has an impact on access to health care. Communities that are experiencing the social determinants of health, experiencing poor access to housing, lower employment, difficulty with transportation, limited number of providers in their area, pharmacies that do not provide all of the kinds of resources, all of the kinds of pharmaceuticals, et cetera. We can even think about, for instance, pharmacy deserts. Neighborhoods, when people live in neighborhoods like this, it's not because they're choosing to live someplace where they don't have resources. It's because these things are structured in ways, and that structure does have real consequences in terms of being able to access care efficiently, being able to get the same high quality of care from the places that people go to. And I would also say that this is not about individuals making individual decisions. The research has shown that. But that our structure is really misaligned so that those who don't need as much actually have access to the best resources, and those who could do a lot more with what's available have more difficulty accessing those resources. And those consequences are not just important for African American and Black people and people living on the margins. What COVID is making clear to us is that if we do not take care of the least of these in our society, it will affect our entire society.
Well said. What tools, as a researcher, are you using to find connections between racism and health disparities?
You know, there's a lot of different kinds of tools. I would say that trying right now, a lot of people have discovered racism, and they've discovered that it affects health. I'm being a little facetious here.
Yes,
but
I got you.
But for many years, we've had to approach it by taking as scientific an approach as possible in order to be taken seriously by our colleagues. And so this involves using many of the same types of survey designs, but asking questions that are truly reflective of the experiences of Black people in terms of their experiences, our experiences with racism and discrimination and other aspects of life, including resilience, strengths, and resources. It also involves qualitative work, right? So incorporating people's stories, because those should inform, they must inform what it is that scientists are doing. I use critical race theory, and it sounds like it's only academic, but what it allows me to do is to think about racism in more nuanced and more sophisticated ways. For instance, one critical race theorist, Cheryl Harris, has looked at this in the law and discovered that one way that the courts have played a role in helping to maintain disparities is by preserving the rights of whites as if it were a property right. So the question is, what kinds of strategies are embedded within public health that help to actually reinforce disparities, not eliminate them? And that's just one tool. It's a thought tool in addition to the scientific methods tools. And so we use all those scientific methods that are available. And in addition, it's also important for us to be able to connect to community to inform our work and to connect to theory that's rooted in what I will say anti-racism approaches in order to do the scientific work differently.
Indeed. Let's connect those tools to your personal research. How have you connected racism-related factors to disparities in HIV care?
Mm-hmm. So in a number of ways, one has been to try to understand what kinds of barriers African American people face if they have access to HIV testing, because we know that HIV testing, getting tested and diagnosed early, is really one of the most important ways to reduce all of the quote-unquote bad stuff of HIV infection, right? It improves a person's chances of staying healthy other than HIV infection longer. And one thing that that I've learned is that African Americans do perceive racism as existing in society. And some of the research has focused on, trying to get African Americans not to perceive racism, or wondering if it is even good for African American people to perceive racism. But my research suggests that perceiving it is not the problem. Experiencing it is.
Yes.
And that for people who perceive it, that they may actually do proactive things to protect their health. And so it's that sort of racial consciousness, that sense of awareness about racism existing that actually can be a tool for empowerment. And so that's one way that we've done that. That work, a lot of that work is done with either people who could access a public health clinic or a regular healthcare system, or those who are already in the healthcare system, and surveying them and also looking at their medical records to see what kinds of things their providers, what kinds of decisions their providers make on their behalf, what kinds of resources they take advantage of, whether or not they accept testing if it's offered to them. Those are the kinds of questions that I'm interested in, or along one stream of my work in that area.
In your expert opinion, what are the most practical means of communicating the need to vaccinate, quarantine, and physically distance oneself to historically abused and misled populations harboring mistrust? This is a hard pill to swallow for many people who have experienced so much, through the years. In your opinion, what are some of the practical means of communicating the need to get vaccinated in spite of that information?
This is such an important question. And I would start by saying that we have to recognize that people who have experienced racism in the medical system and in the healthcare system, in public health, are not delusional for having a sense of mistrust.
Right,
exactly.
We, as public health people, our goal should be to educate people, to provide the resources and the means for people to be able to make the best decisions they can for their well-being. And we have to honor that people do try to make the best decisions they can for their own well-being. And so then I think the first step that we have to take is to address the issue of the lack of trustworthiness that has led to the mistrust in the first place. The second thing is actually to listen to the questions and respond to them. There are a lot of, and here I see parallels, the mistrust that has to do with the COVID vaccine, and a lot of mistrust that existed in the past and still to some extent around HIV prevention. And so I think the first step is actually to engage in conversations where people can actually voice those concerns and have the questions that they have, for instance, about what does it mean for a vaccine to be made available so rapidly? That's a conversation we can hold.
Yeah.
And that's different than simply saying, never mind that, just quick, take the vaccine. So I think that we'll have a more lasting impact by really listening and engaging first
hold that thought.
With.
Hold that thought. We're going to continue in one moment. We're going to have our last station break. I got to pay the bills. And then we'll be back in one moment on Uncontrolled Substance with Dr. Cozzette. Thank you, Dr. Ford.
Thank you.
Uncontrolled Substance.
With COVID-19, aka coronavirus, spreading throughout our country, we're going through some trying times. It's imperative that we do the right thing. Keep your social distancing or physical distancing and understand the importance of monitoring your family health situation. Let's all do our part to help control the spread of this deadly virus. I'm Letticy, and I approve this message.
The Real Urban Radio Network is streaming live on the World Wide Web at www.realurbanradio.com. Log on for the best old school and today's R&B. Can't get to a computer? No problem. Download our app from your smartphone app store. Just search for the Real Urban Radio Network.
Uncontrolled Substance. Uncontrolled Substance.
Welcome back to Uncontrolled Substance. We are now in the checkout with Dr. Chandra Ford. Doctor, we want to thank you for your forthcoming knowledge. We're very blessed to be able to speak with you, and we want to continue talking about how to engage with and honestly respond to the concerns of people in historically misled communities who might be struggling with the concept of whether to get vaccinated.
Yes, that's totally understandable. It's totally understandable that many in our community have fears and concerns. In fact, many communities have fears and concerns. And I think the best we can do is to respect and honor those concerns through meaningful engagement with folks, and not just circumventing those concerns to get them to take the vaccine. So I would partner those two. I would marry that, having the conversation about the mistrust and encouraging vaccination as appropriate.
Definitely. So in the checkout, we want to definitely offer solutions to all that we've talked about before. And so we have this pretty hard-hitting question for you. Okay. How might all clinicians and medical professionals, regardless of race, recognize and begin to unpack their implicit biases before making a fatal misjudgment?
I think it's important to remember, first of all, that implicit biases are structured. They're not arbitrary. That's why we can predict, for instance, when we think about them with policing, the direction that those implicit biases will be in. So let's start at the top. We can start at the top with policy that mandates training on these issues, but more importantly, that makes it mandatory and penalizes institutions or entities for not achieving equity or for engaging in behaviors and practices that reflect racism or indeed are racism. So we can think broadly in terms of policy outside of institutions, but also within institutions. And I think it's important to have an element of enforcement. And then for communities, I think it's really important for people to realize that we can advocate for ourselves and that we can ask for more. We can require something from the institutions that serve us, from healthcare institutions, from researchers, and that's okay. I also would just add that there is a lot of resilience in the African American community, and
yes, ma'am.
Our sense of family and so forth is something, I think, rethinking how we connect to that, bringing it into this current era is something that will carry us through the pandemic. So we all have family reunions. We all have ways of connecting. What is the 2021 version of that? That's where I think we need to go.
Wow. As a physician, it's overwhelming to think about what we would have to do to really make it equitable in terms of providing compassionate, healthcare to all. And listening to you, it just reinforces the need for us to really face the elephant in the room, and we cannot ignore racial injustice and inequities that come about as a result of racism in all industries, not just in healthcare, but particularly in healthcare and public health. And so when I think about the fact that we're on the world stage and everyone's looking at us, the United States, and this pandemic has revealed inequity to even a greater extent in healthcare to the global community. Our image has been totally downrated as a result of our inability to get a handle on this thing. Race has played a huge part in that. Can you speak to whether or not our image has been impacted by this, or do you think it's not that deep?
Our image has been impacted by it globally, and historians such as Gerald Horne point to times in the past, such as during the 50s and 60s, when we were able to leverage that global reputation, the fact that it was being threatened, as a way to make advances for civil rights and equity. And I think we're in that positive place now. The Congressional Black Caucus, the Biden administration, Vice President Kamala Harris have all expressed interest in achieving equity in healthcare and addressing racism as a way to do that. And part of the motivation for that, and I think part of the leverage we now have, is that doing so will improve our reputation in the global community, because the United States is supposed to be this place where diversity and plurality can thrive. And this pandemic is putting us in a position to be able to demonstrate that if we can get our act together. And I'm optimistic that we still can, that there are strides we can take that push us towards equity with respect to the COVID-19 pandemic, however dire it currently is.
I'm with you. I am totally with you in terms of being optimistic about the potential of seeing us do better and becoming better than we have ever been historically, and to put aside, not even aside, to acknowledge, embrace, and then put it in proper context so that we would be empowered to do better.
Yes.
Is the point of it all, I think. When I think about the last few minutes that we have, I want to pause and give you an opportunity. Is there anything that you want to make sure to say to our listeners before we conclude on the show today?
I would say that each little thing that we do does matter. And so it's important to, as Reverend Jesse Jackson used to say, keep hope alive.
Yeah.
I know it might sound trivial, but it really does matter. And I also would say that even though you may not see us in the community all the time, that there are people, researchers like myself, who have been fighting on the inside for a long time to name racism as a public health issue well before it was popular to do so. In fact, when it was very unpopular and controversial to do it. And that addressing racism explicitly is essential if we're going to move forward. And I even think about Dr. Aisha Cowrie at Kaiser Permanente, who was essentially let go of for talking about racism. And I want to just lift her up because it takes courage to bring ourselves to the work that we do. And that kind of experience is not unusual. I mean, the kind of experience of being suffering backlash as a result of really trying to address racism, especially in the progressive spaces, the West Coast, quote unquote left coast places,
right,
where we're taught that racism is not an issue here. In this moment, I think it's important for us to look out for the ways that racism operates in the helping field, in public health and medicine, in liberal and progressive spaces. Because while we're busy pointing our fingers at neo-Nazis marching in the streets, the primary ways that racism operates, the structural mechanisms, are continuing to keep disparities in place.
Definitely.
So those we have to stay attentive to.
That hits my heart strongly as a West Coast young woman who's witnessing people around her, want to have that push for keeping hope alive. My generation, I feel like, needs to hold on to those words because oftentimes I worry and I pray that we're not falling into cynicism when we're trying to push for improvement in our nation. And at the same time that we're not ignoring our own planks in our own eyes, right? And so I'm really grateful for you to bring all that together.
So we thank you so much, Dr. Ford, for coming on Uncontrolled Substance on today. You are such a gift. Bless you in the work that you're doing. We support you. We would love to have you back on the show again because this is just touching the surface and there's so much that we could cover. But thank you so much for being on the show.
Thank you so much. I'm a huge fan and it's a real pleasure.
Thank you. So that's it for this week or this month on Uncontrolled Substance. Thank you, Lena, for sharing the studio time with me on today.
Thank you so much for having me. This is so exciting.
All righty. So we look forward to seeing everyone or hearing, or you listening in, I guess, on Uncontrolled Substance. We're on the air every fourth Sunday of the month on the Real Urban Radio Network. Download the app or go to the website, www.realurbanradio.com. We'll have Mr. Lena Jones back. Say hi to my baby. I know he's listening, and to my baby Samani, my son. And we look forward to connecting with you all again next month. I know a lot will happen. We'll bring a lot as much as we're able. Go to our different social media platforms. Check us out on our webpage and get the latest in terms of articles and subject matter that we have covered. Thank you again, Lena. It's been a pleasure sharing the platform with you.
I hope to be back.
You will. Thank you.
Uncontrolled Substance.